The COVID-19 pandemic is disproportionately impacting underserved and underrepresented communities. Johnson & Johnson is committed to providing a safe and effective vaccine, ensuring diverse representation in our clinical trials so that all communities may benefit from a potential vaccine.
Greetings, my name is Naomi Smith, and I'm the Research Policy Analyst with the Congressional Black Caucus Foundation, and I am excited to welcome you to the 2020 General Health and Wellness Session, The Realities of COVID-19 and the State of Black Health. Before I introduce our speakers, I would like to thank Johnson & Johnson for their longtime partnership with the Congressional Black Caucus Foundation and the annual legislative conference. Our first speaker has spent much of her career fighting for the equity of families of Illinois and those around the nation. Through fighting for the collection of demographic data as it relates to COVID-19, Congresswoman Robin Kelly is dedicated to expanding access to healthcare for American families. Please welcome Congresswoman Robin Kelly.
Thank you so much. Hi, I'm Congresswoman Robin Kelly, Chair of the Congressional Black Caucus Health Brain Trust. Let me start by saying thank you for joining us. With the COVID-19 pandemic changing plans, I'm glad that ALC is still happening, even if it's online. As much as I miss seeing you all in person, I know that all the traditional benefits of ALC will still come out of this digital convening. Today, we come together to discuss something that could not be more critical, the state of Black health and the realities of COVID-19 double pandemic. However, because this is ALC, we don't just discuss the problems, we'll discuss real actionable solutions that will move us forward and end generations of health disparities. COVID-19 has hit America as two pandemics. We see the effects of it in wealthier, whiter communities and completely different ones in more vulnerable communities of color. This is America. There shouldn't be a two-tiered system, but generations of health disparities, inequities, and a lack of access to care have effectively created two Americas. Even before COVID-19, we lived in a nation where the zip code where you were born determines how long and how well you live. COVID is just the latest in a series of health threats, from diabetes, maternal mortality, to asthma and HIV, that have had a disproportionate impact on our community because we've lacked basic healthcare services for far too long. By now, we've all read the shocking but not surprising statistics showing that our family and loved ones are dying at a higher rate from COVID-19. Based on our knowledge from public health research, we know and can predict these disproportionate outcomes in minority communities. So my questions are three. Can we change the model so the outcomes and predictions change? Where do we go from here? How do we tackle these insidious health disparities that continue to force Black and Brown Americans to live shorter and less healthy lives? It is my mission to combat these disparities head on and provide opportunities for Black Americans to live longer, healthier lives. That is why in 2015, I released the Kelly Report on Health Disparities. You can find it on my website, robinkelly.house.gov. Under the Resources tab, there is a sub-tab for Kelly Reports. This report was the first congressional examination of health disparities in the Black community. It also makes a number of policy recommendations to start reducing and eventually eliminating these disparities. I would encourage you to read the report. If you don't have time to read the whole report, just read the recommendations page. Since that report 5 years ago, I've been working to turn these recommendations into policy. And I'm glad to report that I've had some successes, but there's many more successes that we need to have. The COVID-19 pandemic has made that painfully clear. Right now, we're fighting in Congress to enact federal legislation to address COVID while rebuilding a stronger, more fair system for all. First and foremost, House Democrats through H.R. 3, the Elijah E. Cummings Lower Drug Costs Now Act, are working to lower the cost of prescription drugs. If you can't afford your prescriptions, it's very hard to stay healthy. So we must focus on helping people afford medicine that keeps them strong and well. But we also know that reducing costs saves money. So we want to reinvest those prescription savings in Medicare and Medicaid so we can provide dental, hearing, and vision care to recipients. My bill, H.R. 4650, Medicare Dental Coverage Act of 2019, is part of the H.R. 3 package. It extends dental coverage to seniors enrolled in Medicaid in a Medicare program. I've also introduced a number of COVID-19 specific bills that also address health disparities, like the Community Solution to COVID-19 Act, that is H.R. 7077. This bill I introduced with Senator Cory Booker would create a $1.5 billion grant program for local and grassroots organizations to conduct or expand health disparity elimination work. Let's face it, if we want to end health disparities, we need to invest resources in the communities most impacted by them and empower organizations within these communities to provide aid to build a better future together. From anecdotal stories, I've heard some doctors are having nearly 100% of their patients keep their appointments because Zoom removes the need for taking 2 buses or looking for childcare. My bill, H.R. 7078, Evaluating Disparities and Outcomes of Telehealth during the COVID-19 Emergency Act, would examine how telemedicine helped or hindered the delivery of care during COVID-19. Let's use this moment to study and understand how to use technology and telemedicine to better deliver health care. This bill also found its way into a proposal from the GOP Senate, so I'm hopeful we can advance it in the next pandemic response. We really think that telemedicine or telehealth can be the great equalizer if done right. But perhaps my most important legislation is related to data. We need to truly understand the outsized impact of COVID-19 is having on Black and Brown communities. When this pandemic began, the CDC was not really collecting and analyzing racial disparity data. The only data we had was from courageous state leaders publishing data on their cases in their states. When my bill, the Equitable Data Collection and Disclosure Act, was added to the 4th response bill, it required the CDC to send a report to Congress on the effect of COVID-19. When we got the first report, I must say it was less than 3 pages. Frankly, it was more a series of links than an analysis. We sent that right back and talked to the CDC director and his folks and told them we need a much better report the next time. We know there's a lot of things that need to be done. States don't report in the same way, don't have the same resources from one state to another. So we definitely have to have a national approach. But at the end of the day, we deserve to live in one America, not an inequitable America with lower standards for Black and Brown people. We deserve a public health system that works for all Americans. We deserve healthcare because healthcare is a human right. This is our fight, and together I know we'll win. Thank you again. Thank you for inviting me to be a part of this, and good luck with everybody's presentation. Thank you.
Thank you, Congresswoman Kelly. We always appreciate your good words, and I'm excited to see your recommendations moving forward and how it'll affect us in our everyday lives. Now, I would like to introduce another champion for equitable healthcare in Illinois and for those around the nation, Congresswoman Lauren Underwood. In her first term in Congress, Representative Underwood has used her experience as a nurse to advocate for affordable and quality healthcare, and specifically hold concern for Black maternal health as it relates to the current pandemic. Please welcome Congresswoman Lauren Underwood.
Well, hi, everybody. Thank you so much, Naomi, for that kind introduction. I'd also like to thank Johnson & Johnson for hosting this important session on COVID-19 and the state of Black health. And I'd like to thank the Congressional Black Caucus Foundation for taking on the monumental task of shifting this year's annual legislative conference to a virtual setting. I also want to give a shout out to my colleague, Congresswoman Robin Kelly, who's been a champion on Black maternal health and so many other pressing racial equity issues, particularly as the chair of the Congressional Black Caucus Health Brain Trust. Long before COVID-19, Congresswoman Kelly was tackling the glaring injustices that cut across every dimension of the United States healthcare system. And this pandemic has not only been shining a bright light on those inequities, it's worsened them. We see it in the context of exposure to the virus. The Associated Press analyzed data on essential workers in large US cities and found that these workers are more likely to be women than men and more likely to be Black or brown than white. And we see it in the context of COVID-19 outcomes as well. The Centers for Disease Control and Prevention reports that African Americans are more than 4.5 times as likely as white Americans to be hospitalized from COVID-19 and more than twice as likely to die. We see these disparities in the context of maternal health, where the CDC reports that Black and Hispanic pregnant women appear to be disproportionately affected by COVID-19 during pregnancy. But the heightened risks facing Black pregnant women are not new, because even before COVID-19, Black women were 3 to 4 times more likely to die from pregnancy-related causes than white women. In my state of Illinois, maternal mortality rates for Black women are 6 times higher than white women. And these trends cut across education level, income, and any other demographic trait. In fact, Black women with a college degree are more likely to die giving birth than white women who dropped out of high school. In response to these glaring statistics and the stories behind them, I joined with Congresswoman Alma Adams to co-found the Black Maternal Health Caucus in April of 2019. Our caucus is dedicated to elevating the Black maternal health crisis in Congress and advancing policy solutions to save lives and end disparities. One of these solutions is extending postpartum Medicaid coverage to a full year after delivery, a policy that has been long championed by Congresswoman Kelly and passed out of the House of Representatives in June. Another policy that we focused on is the Black Maternal Health Momnibus Act, which I introduced with Senator Kamala Harris and Congresswoman Adams in March 2020. The Momnibus includes 9 bills to comprehensively address every dimension of the Black maternal health crisis in America. We developed the legislation by centering the voices of Black women and elevating solutions that have been championed by Black women-led organizations across the country. We're going to need that same deliberative approach to address the disparities that have emerged in the COVID-19 outcomes. First, that means that we have to collect comprehensive data stratified by race, ethnicity, and other relevant factors to build the complete understanding of this virus. And that is what will be needed to inform data-driven, evidence-based policies to promote equity. We also need to make targeted public health investments, providing communities of color with the support that they need to promote health and safety during the pandemic and beyond. And that's why I joined Senator Elizabeth Warren to introduce the Maternal Health Pandemic Response Act, which would enhance data collection and research related to COVID-19 and pregnancy, and make lasting investments in quality maternal health care and support, particularly for Black women and other women of color. I also introduced the Community Immunity During COVID-19 Act to promote vaccination during this pandemic, including funding for culturally appropriate community-specific initiatives to promote vaccine confidence in underserved areas through partnerships with local immunization providers and community-based organizations. And finally, we have to recognize that while we're confronting a once-in-a-generation health crisis, we also have a once-in-a-generation opportunity to build a more equitable healthcare system for everyone. Last year, I introduced the Healthcare Affordability Act to lower the cost of health insurance premiums by hundreds or thousands of dollars for millions of Americans. And in June of this year, I was proud to join my House colleagues in passing the Patient Protection and Affordable Care Enhancement Act, which included that bill to reduce insurance costs. This historic legislative package delivers on a promise to the people and for the people, ensuring every American citizen has access to quality, affordable healthcare. By investing in Black communities specifically and expanding access to affordable care for everyone, we can close the glaring racial disparities that have plagued our healthcare system for far too long. And equity is part of our past, and sadly, it's part of our present, but it doesn't have to be part of our future. We can make different policy choices, better policy choices that will lead to better outcomes. The inspiring women that you're going to hear from later in this session will describe a path forward, and I'm grateful to each of them for their leadership on these critically important issues. Thank you all so much for being part of today's conversation and for the opportunity to join you. I hope that we're all together again in person next year, but until then, please take good care of yourselves. Thank you so much.
Thank you, Congresswoman Underwood. It was really great to have you, and I can't wait to hear this panel talk more about the importance of data collection as it relates to all health concerns. So thank you so much. Now I will introduce the moderators for today's General Health and Wellness session, Ms. Joy D. Calloway. Ms. Calloway has been a longtime leader in the healthcare industry with over 25 years of professional healthcare and nonprofit leadership experience. Currently serving as the Interim Executive Director for the National Association of Health Service Executives, Joy is a 3-time graduate of the University of Michigan, where she remains very active with her alma mater, mentoring young professionals. From 2013 to 2018, Ms. Calloway served as President and Chief Executive Officer of the New Center Community Mental Health Services in Detroit, where she revived and repositioned an agency striving to remain relevant and impactful. Preceding this role, Ms. Calloway has held leadership positions as the Associate Vice President for Community and Rural Network Development for St. Joseph Mercy Oakland Hospital, Executive Director of Metro Health Services, Inc., and founding Chief Executive Officer of Oakland Primary Health Services, Inc., the first and only federally qualified primary care health facility servicing low-income and medically underserved populations in Oakland County, Michigan. Thank you, Ms. Calloway, and we look forward to this panel.
Thank you so much, Naomi. It is a joy to be here among such powerhouse women who I absolutely am pleased to be with today. What you're going to hear today is going to really change your life and change your thoughts on this pandemic. We know that not since 1917 have we had a scourge on our land quite like COVID-19. With over 177,000 deaths of Americans, this has overshadowed Ebola, Zika, SARS. The impact of this pandemic will last for years to come. When we consider the societal implications, the broad impact, and even the political polarization, this is something we have never had to deal with in this manner. But today, you have the opportunity to hear from experts who are well-schooled in this topic, who have spent their careers fighting for justice in healthcare in underserved communities. And I am again thrilled to say they are all sisters, and I can't wait to hear what they have to say. Please know that our response to this pandemic will set the tone for healthcare for years, if not decades to come. Please join me in this conversation. I am thrilled to introduce our 3 powerhouse women. They are going to set the tone for our time today by giving a brief introduction of their thoughts on this pandemic. And then I'm going to have the opportunity to ask a number of questions of each of them to really get an understanding of where they are in their work and how they are helping our communities. Please join me as I first introduce Dr. Makaya Doogie. Dr. Doogie is the head of clinical development and medical affairs at Janssen Vaccines and Prevention, which is the pharmaceutical arm of Johnson & Johnson. There she leads a team of physicians and scientists that lead the clinical development of a portfolio of viral and bacterial vaccine programs. During her time at J&J, Dr. Doogie has served in various medical leadership roles on multiple viral vectored vaccine development programs focused on tuberculosis, malaria, RSV, Zika, and Ebola, as well as therapeutic immunization antibody programs. Dr. Doogie is a medical director with a degree from the University of Wisconsin-Madison. She is doubly boarded in family practice and preventive medicine. She has also obtained a master's in public health from Johns Hopkins Bloomberg School of Public Health in Maryland. Dr. Doogie.
Good morning, and thank you for the opportunity to participate in this very important panel, and for that lovely introduction. In addition to my current role at Johnson & Johnson, I have an 18-year background of working on infectious diseases and preventive vaccines, largely initially focused on TB, malaria, HIV, as well as looking at low-cost solutions to reducing perinatal morbidity and mortality in low-income settings. So I've seen firsthand how much skin color and socioeconomic status can affect health outcomes. At Johnson & Johnson, we are absolutely committed to developing medicines and vaccines that address the highest unmet medical need, which is reflected certainly in the vaccine portfolio that I oversee. We have an HIV vaccine that we are evaluating. It's in the efficacy phase in women who are at the highest risk probably in the world in Southern African countries, as well as men who have sex with men and transgender individuals in the Americas, including the US. We have a respiratory syncytial virus vaccine candidate that's also in the efficacy stages, and it's like influenza. It affects the extremes of age, infants and the elderly, and we also see the impact on certain communities disproportionately. We also, as was mentioned, just recently licensed our Ebola vaccine regimen and in Europe, and that's our first licensure for the company, so we're very excited about that. And I have to say that that has fueled in part our commitment to developing a COVID vaccine to address this. And we really are leveraging our experience from that accelerated program that started in 2014 to 2016. In West Africa. And we're leveraging the vaccine technologies, which I'll talk a little bit more about today, that we use for a number of our vaccine candidates against a variety of diseases. And we've now administered this platform to over 90,000 individuals around the world, including adults, elderly, pregnant women, HIV positive adults, and children down to the age of 4 months. So that safety experience really has helped support the activities that we're doing currently with COVID-19. And from this accelerated experience, one, we've demonstrated that we can do accelerated clinical development in a safe and very expeditious fashion, and we can do it under extenuating circumstances. I think about the experience we had in Sierra Leone, trying to manage doing an efficacy trial in an area that had never been exposed to clinical research. Many of the people in the community had never seen a doctor for anything at all. And so community engagement is one of the critical pillars in that setting, but also I think in the setting that we're going to talk about a lot today. So the other thing that we've learned is that every day matters. Anything that you can do to streamline a process that makes it shorter, if you have to work weekends or overnight repetitively to move things ahead, that could save lives. And so that is the ethos that we're embracing for this accelerated development program. And we aim to produce over 1 billion doses of vaccine to be able to supply and support the needs of the US population, but also globally. It's been said, and said quite well by Congresswoman Kelly and Underwood, COVID-19 disproportionately affects the Black and Brown communities. We're 3 times as likely to become infected, 5 times as likely to be hospitalized compared to whites. And this is not dissimilar from many of the outcomes that we see for other medical conditions. Access to appropriate medical care, accurate information about the disease, as well as preventive measures are critical. The importance of diverse participation in clinical trials enables evaluation of impact of interventions broadly and in a generalizable way, and can also down the road help to improve the acceptability of interventions. So I'm very much looking forward to engaging on how we can prioritize our community needs and work towards preventive solutions and improvement of health outcomes in this space. Thank you.
Thank you so much, Dr. Doogie. I'd now like to introduce Dr. Kamikia Corbett, who I first learned about through a Black Girl Magic blog to which I subscribed. It was a big pop-up that said, here is a Black girl you must know who's fighting against COVID-19. I'm pleased to introduce her. She is a research fellow at the NIH Vaccine Research Center. Her career began at the University of Maryland, Baltimore County, where she was a Mayoff Scholar and an NIH undergraduate scholar. Dr. Corbett received her BS in Biological Sciences with a secondary major in sociology in 2008. After a 1-year post-baccalaureate program at NIH, she enrolled at the University of North Carolina, Chapel Hill, where she earned her PhD in microbiology and immunology. She is currently the scientific lead for the project at the National Institute of Health to develop a vaccine against this new coronavirus. She recently briefed the president about potential COVID-19 vaccines, and she now focuses on assessing and improving the immunogenicity of novel vaccine platforms for coronaviruses and influenza. She combines her scientific interests with her knack for mentoring, and she hopes to one day become an independent principal investigator. With all these other things she's done successfully, I am sure that is yet to come. Dr. Corbett, the floor is yours.
Thank you so much for that kind introduction. It is a pleasure to be a part of this panel today, particularly with these other women who have so much to offer in regards to the topic at hand. My personal stance on the topic is that I was happy to see the title because it really merges two of my passions together in one really discreet and truthful and honest conversation. And so I'm happy to be here. So by way of introduction, so I got my PhD in 2014, and immediately after I started working at the Vaccine Research Center for the National Institutes of Health, where I am a research fellow, but further a scientific lead for preclinical development of coronavirus vaccines. And just by way of, for 6 years, really slugging away at really understanding how vaccine responses are best handled for coronaviruses, particularly in the case of MERS, which had steady state transmission, throughout the Middle East up until now. We were able to deploy a vaccine for the novel coronavirus to phase 1 clinical trial within 66 days. And so I have this passion for vaccinology and virology and infectious diseases that has been honed throughout the years by way of my PhD work and the work that I'm doing now, and particularly around coronaviruses. But then there is also the personal side in that I obviously sit here as a Black woman, and I understand wholeheartedly how devastating this virus has become to our community. And it's really the interplay of what's happening with the vaccines as we are trying to deploy them into licensure, et cetera, and also what's happening with the virus in the community is something that really sticks out to me and really taps into my interest because, as was mentioned in the introduction, I double majored in sociology. And by part of that double major, and then also part of being at a university in undergrad that was in Baltimore, I took part in a data collection for a study that assessed health outcomes in what they call neighborhoods of diversity, but layman speaking, the hood. And how health outcomes in those neighborhoods are affected by just the zip code and your social standing in that space. And so it was really interesting to watch the bridging of my interest in virology and vaccinology unfold as I was also doing this sociology research essentially on the side. And then there's the personal experience of being an expert in a thing and then watching people around you succumb to it, or also really being an expert in, the biomedical sciences and still having, a mom who ails from diabetes and high blood pressure, a sister who, had a stillbirth on my birthday, and these kinds of things that are all things that disproportionately affect the Black community. And so I got into vaccines because I felt that the experience, the expertise that I have and the experiences that I have from vaccines are, historically speaking, some of the best medical counter interventions for prevention of diseases. They are the way to the cure, in my opinion. And so where I sit, I'm just really excited to be able to give you the personal view from a vaccine development standpoint, and as they say, a coronavirus expert. And then also the personal view from, the side jobs that I have where I'm invested in health outcomes for Black communities and other communities of color. So thank you again for having me.
Thank you so much for those comments. I am so excited now to introduce our third powerhouse woman, Dr. Kamara Phyllis-Jones. Dr. Kamara Phyllis-Jones is a senior fellow at the Satcher Health Leadership Institute. She is a family physician and an epidemiologist whose work focuses on naming, measuring, and addressing the impacts of racism on the health and well-being of the nation. She is a past president of the American Public Health Association and is currently an adjunct professor at the Morehouse School of Medicine, as well as an adjunct professor at the Rollins School of Public Health at Emory. She focuses on the social interpretation of how one looks, which unfairly disadvantages some individuals and communities and unfairly advantages other individuals and communities and saps the strength of the whole society through the waste of human resources. I will tell you that through my study of her work, I now know that it is racism, not race, that is a risk factor for COVID. Dr. Kamara, we're looking forward to your comments.
Thank you very much. Thank you, Ms. Calloway. And I am excited to round out what Drs. Doogie and Corbett have shared about vaccine development, because a vaccine is going to be one way for us to try to get our way out of this pandemic. But it's not the only cure, and it's also not going to get us out of the infant mortality disparities or the maternal mortality disparities and the like. And so what we need to understand is, yes, we have the COVID-19 pandemic, but we also have the endemic pandemic, the thing that's been with us for centuries, which is racism. What I want to do right now, COVID-19 pulled the sheets off of US racism and the structural inequities that it has established and that it perpetuates. But many people don't recognize that racism exists. They don't know how to talk about it. They hear people now affirming that Black Lives Matter. They hear people saying structural racism, systemic racism, and don't really know what to do with that. So what I would like to share in just about 4 or 5 minutes is a story that I tell, one of my teaching stories, my allegories on race and racism, that will equip you to talk to your neighbors or coworkers or whatever, or even to have a deeper understanding yourselves that yes, racism exists and this is how it operates, that actually racism is a system, it's not an individual thing. So this story, I call it Dual Reality, a restaurant saga. It's based on an experience that I had as a medical student. First year medical school, here I am one Saturday, because I'm very diligent, very hardworking and studious. Wake up early in the morning Saturday and I'm studying long and hard. And afternoon comes and some friends come over. So they don't distract me. We all start studying together, long and hard. And now it's evening and it's getting later and later and we get hungry and I have no food in the apartment. Okay, that was typical of me. So my friends understood. They were like, never mind, Kamara, let's go into town and find something to eat. So we do. We walk into town, we find a restaurant. We walk in, we sit down, the menus were presented. We order our food and the food is served. So here we are eating. And so now you're like, Dr. Jones, that's not a very illuminating story about racism. Well, hold on. As we are sitting here eating, I look across the room and I noticed a sign that's a startling revelation to me about racism. So now I've intrigued you and you're like, Dr. Jones, what did the sign say? Well, what did the sign say? The sign said, open. So now maybe I've lost many of you. So let me recap. Here we are sitting together in a restaurant eating. I look over, I see a sign that says open. If I hadn't thought anything more about it, I would have assumed that other hungry people could walk in, sit down, order their food and eat. But because I knew something about the two-sided nature of those signs, I recognized that now, in fact, the restaurant was closed due to the hour, but firmly closed, and that other hungry people just a few feet away from me, but on the other side of that sign, would not be able to come in, sit down, order their food and eat. And that's when I understood that racism structures open, closed signs in our society, that racism structures, if you will, a dual reality. And for those who are sitting inside the restaurant, at the table of opportunity, eating, and they look up and they see a sign that says open, they don't even recognize that there's a two-sided sign going on, because it's difficult for any of us to recognize a system of inequity that privileges us. So It is difficult for men, for example, to recognize male privilege and sexism. It is difficult for white Americans to recognize white privilege and racism. It is difficult for all Americans to recognize our American privilege in the global context. But those on the outside, they are very well aware that there's a two-sided sign going on because it proclaims closed to them, but they can look through the window and see people inside eating. So back inside the restaurant, to those who ask, is there really a two-sided sign? Does racism really exist? I say, I know it's hard for you to know when you only see open. In fact, that's part of your privilege, not to have to know. But once you do know, you can choose to act. So it's not a scary thing to name racism. It's actually an empowering thing to name racism. It doesn't even compel you to, act, but it does equip you to act so that if you care about those on the other side of the sign, which is an if, but if you do, why, you could even talk to the restaurant owner who is, after all, inside with you. And you could say, restaurant owner, there are hungry people outside. Why don't you open the door, let them come in? You'll make more money, and oh, the conversations we could have. Or maybe what you'll do is pass food through the window or try to tear down the sign and break through the door. But at least what you won't do is be sitting back saying, wonder why those people don't just come on in and sit down and eat. Because you'll understand something about the two-sided nature of that sign. So just to recap, this story has been to let us know racism's not just structuring a two-sided sign. It's the sign, it's the door, it's the lock, and we need to go beyond even just recognizing the two-sided sign. We need to, because if we just say a thing, then from 6 months from now, the racism denial that is the baseline state of this country is so seductive that if we just say that racism is bad, we'll forget why we said that thing. But if we start acting, we will not forget why we started acting. So thank you very much for the opportunity to share that story.
Absolutely. Thank you so much, Dr. Jones, for sharing that. And I hope it is not lost on our participants, because it's not lost on me that there is power on this panel. Again, I say powerhouse Black women, and we really are thrilled again to have you. It's also not lost on me that as we are talking about this COVID pandemic, and I'm looking at these amazing women who are in this fight every day, it's also not lost that those countries around the world with the lowest death rates for coronavirus are all led by, wait for it, women. Germany and Prime Minister Merkel, New Zealand Prime Minister Ardern, Finland Prime Minister Marin, all women in this fight. So thank you. Ladies, you have all mentioned in some way or another how this pandemic pulled the sheets off of the many ongoing challenges in the Black community. Health disparities, the digital divide. It has also shown us the wealth gap, quite frankly, as we've moved through this place. And historically, we have always found a way out. We've overcome, we've empowered ourselves, we've been resilient. And quite frankly, that is something that we should be thankful for and recognize. Yes, are the preventative measures that our communities should take to ensure that we are protected from viruses like this. Can we start with Dr. Doogie? And I'd love to hear from all of you.
Could you please repeat the question? I'm sorry, because you were cutting in and out. I'm sorry.
No worries. You all have all mentioned that this pandemic has really pulled the sheets off of and shone a light on all of the ongoing challenges in the Black community, including the wealth gap, the health disparities, the digital divide. And in the past, as a community, we have overcome challenges, we have empowered ourselves, we have maintained our resiliency, but we also know that prevention is important. So I'd like to hear from each of you, just briefly, about what preventative measures you all would recommend that we should take as a community to help protect us against viruses like this.
So I'll start by saying, wear a mask. There are a lot of people who have decided they don't want to wear one. It may not be cool. It's their right not to wear one. But being aware that you're protecting yourself from people who are asymptomatic and might be transmitting the virus to you. But it also protects everyone else around you if you are that person who is infected. So I think that's really important. And the simplest thing is lots of hand washing. I'll be very curious to see what happens this influenza season with all of these measures. I suspect there will be lower rates of all of those things because of the simple fact that people are social distancing, washing their hands, and wearing their masks appropriately as much as that's. So that would be my primary prevention advice before we have a vaccine that can be utilized.
Thank you so much. And those are the basics we continue to hear. If Doctors Corbett or Jones have nothing additional to add, I'll move on to another question.
Well, I think that we also need to, yes, I think that we also need to support the post office. We need to we need to make sure that we have participated in the census. We need to make sure that we're all registered to vote and exercise that right. Because those things go to the deeper structural factors and how we as individuals can exercise our citizenship rights. And also in the workplace, what's happening is that Black folks are getting more infected because we're more exposed and less protected. And once infected, we're more likely to die because we're more burdened by chronic diseases with less access to health care. So we need to even work with the Occupational Safety and Health Administration, part of CDC, to ask them to please put in place workplace standards, right, for social distancing and meatpacking plants or warehouses or anything like that. We need to find a way to encourage increased production of personal protective equipment so that all essential workers can be protected. Not just the essential workers in hospitals, but essential workers who are bus drivers or, you know, are cleaning the hospitals or are delivering the mail and all of that.
I really appreciate that. It's another look at what we can do preventatively. There are things that we can do physically every day, to Dr. Doogie's point, and then things that we can do structurally to help us that many of us might not have considered as a preventive measure. Thank you for that. Dr. Corbett, anything you'd like to add?
You know, my only addition is that as a vaccine advocate and a vaccinologist, so to speak, I do have to mention that if and when a vaccine or vaccines become available, that it is our, you know, citizen duty to protect ourselves and to protect the people around us. And, you know, a vaccine, depending on how efficacious it is, will most certainly be more efficacious than walking the streets in the middle of a pandemic blindly without your immune system having any preventive mechanism to prevent you from getting disease. And so understanding how vaccines work, starting now to really put some faith and some trust behind the vaccines that are in the queue for licensure, and asking the types of questions that you need to ask to make sure that you have wrapped your mind around how these vaccines will work so that you feel like you might be able to take them when they do become available is extremely important. And even if you feel like you're not in the population of people who might be plagued by the more severe COVID-19 illnesses, understanding that vaccines are not just for you and yourself, but it is a community effort, and protecting each other by herd immunity is also important.
Thank you so much for that. And you've actually ushered in the next topic I want all of you to speak on, because this thing about vaccination is important, but we know for good reason that Black folks and other communities of color are very wary when it comes to vaccines. Many of us don't even take the flu vaccine. And now we're asking to take a vaccine for this very novel virus. Again, for good reasons. Dare I say Tuskegee? Dare I say Henrietta Lacks? Dare I say Dr. J. Marion Sims? So given that backdrop historically, and I'd like to start with Dr. Doogie and work my way back around, what would you say to us, speak to us about not only the importance, and we get it, but how do we get our communities around this historical blockage so that we can be part of clinical trials, et cetera?
So I think it starts with the conversation, and certainly from an industry perspective, there's even probably more distrust. We have to make more of an effort to engage in all of the communities. And this is not something that happens overnight. So for a lot of our other programs, we actually have initiatives to focus specifically on what we call patient voice, where we talk to people and interview a wider range of people and find out what their concerns are about a therapeutic or a vaccine. What is the issue? What would you like to understand more about? Providing digestible information, because if you ask me to explain how our vaccine works, it's not the easiest thing to explain in simple terms. And so making sure that we are connecting with people and providing information that's understandable to them, I think, is one effort that we can make. And it's building trust. So yes, these atrocities in clinical research have occurred. There have been a lot of improvements that have been made. And so now it's going from, okay, I don't want to participate in this clinical trial, to, oh, but this might be actually beneficial. And there are benefits to participating in clinical research. You feel more comfortable if you have a good experience, or let's say you don't have a bad experience. If your neighbor asks you about it, they might be more likely to say, hey, maybe I would consider that. So I think it's a long-term process of engagement and making sure that you have a connection, you've built a trust, and you spend the time addressing the concerns and questions of the community. And I think that can go a long way.
I appreciate that. Dr. Corbett, could you speak to the same?
Yeah, I completely agree that this rebuilding of trust, because that's essentially what it is, trust was really snatched away from us in so many ways, and now we have to rebuild it from our side. It is going to take a lot of community engagement. It's going to take, I like to say that with anything, you have to start with empathy. It's going to take us to pare down our understanding from a scientific perspective and really dig deep into our understanding from an empathetic perspective. And then once we get there, really doing it piece by piece and in a very transparent way, not holding data in a vacuum, and really putting things, as she said, that are digestible in front of people so that they understand what is coming out of the trials that they have particularly participated in. And then I like to remind people also, from a participant perspective, that you are allowed to hold, hold us accountable for your questions and, for whatever it is that you feel like you need to know to feel comfortable around participating in a clinical trial. I think that people rarely understand that it is a two-way street, and that what you're doing is a volunteer effort. And so it is the duty of the clinical trial to make sure that you are comfortable and that you are well-read and well understood around what's happening to you. Yeah.
Thank you so much. Dr. Jones, would you round out this question and then we'll move to the next? What
Yes.
can we be doing to encourage our community and prepare them?
So I would say two things. First of all, it shouldn't be all of a sudden you're coming into the community when there's a vaccine. So I think that efforts to invest in contact tracers who really are like community health workers early on right now for all of the management of this thing. We have been treating COVID-19 as if it were a medical care issue, when in fact it's a public health issue. And so we've been like looking at people one by one. We need to get a handle on the public health area of this. And so community health workers for contact tracing, but for other things. If you have a whole army of people who live down the street who have been talking to you about how to stay safe all along, you're more likely to accept their advice when a vaccine becomes available. The other thing is we need to be investing in other people in terms of the vaccine development. So maybe HBCUs, historically Black colleges and universities, or African countries. So there have been some, you hear, little things about promising approaches from the African continent that aren't really getting play. My fear is that European, especially vaccine developers who say, well, we have something, but we can't really test it now in our context because there's not enough community transmission. We need to go to the African continent to test even for the efficacy piece of it. Like, don't come to me like that. Don't come to me like that, you know? And the last thing I say is, at the point, although we're most impacted, and maybe we should get the vaccine first, we shouldn't get it before the leadership of this country. So at the point where the president, vice president, all of the cabinet, you know, the Congress and the Senate gets the vaccine, that's when it should also be introduced in Black communities. And then we should be the first community that gets it because we've been hardest hit, but not as any kind of testing. That would reassure me.
Thank you so much. Excellent points.
I do have a point to make in that many of these vaccine trials are not happening in Africa, actually. The phase 3 efficacy trials are for the most part, US based. So I just had to make sure that was very clear. And then the other thing is that, you know, there is this fine balance between the level of, people say that to me actually all the time. Well, like, why don't you go test why don't you take the vaccine yourself? And I'm like, I totally would. Like, can someone get that approved ethically so I can? And, but yeah, I mean, I think that there is a fine balance between the privilege that comes from having access to the vaccine and being able to take it first versus, you know, spreading the wealth essentially and to the most vulnerable populations. And so that's something that has to really, I mean, it's beyond me and really does need to be worked out, because I agree that you see someone taking it and then you feel more comfortable because, well, you know, if they took it and they're okay, then we would feel more comfortable. But so, I mean, there's a lot that really needs to be done. And I think that one thing that's good and bad for me is that because this is so early on in my career, this becomes a large learning experience for me and for the field in general. Because one of the things that's been brought up constantly is that, well, you know what? Black people actually have never been asked to be in trials before this. And there really hasn't been a spotlight on the disproportional amount of different populations in clinical trials before this. But now that we're shining the spotlight there, we have to learn from what's happening around it. And so it's going to be just a large learning experiment, so to speak.
Thank you. And speaking of privilege, it's a great privilege to have this conversation with you all that are working in it every day to help kind of bust some of the myths and bring the facts to the table, because we need to hear this so that we can take part in being part of the solution. Dr. Doogie, if you could talk to us in layman's terms, please. How is the vaccine being developed? And tell us generally where you all are in the timeline. We know that we need to do some acceleration. While you're accelerating, what is Johnson & Johnson doing to ensure safety and efficacy? Can you speak to that compound question?
Sure, and remind me if I missed something. Yeah, so first the vaccine construct. So we are using an adenovirus as a vector. So that means that's sort of a delivery system for the protein that we ultimately would like to expose to the body. So adenoviruses cause common colds, essentially. We remove the genes that allow it to reproduce, so that basically it can enter your body, but it can't do anything after that, can't cause a cold, etc. And it's basically a delivery vehicle for a piece of DNA that encodes, in the case of COVID-19 or SARS-CoV-2, the spike protein. And that spike protein is what helps the virus normally get into our cells. So when it instructs our cells to make that protein, and the protein is then presented to our immune system. And what it does is it gives it memory, and it allows it to recognize that specific protein. So when you are actually infected, your immune system immediately acts faster than it would as if you were exposed to it the first time. And that's how it prevents, that's how we hope it will prevent infection or disease. So that's the construct that we're using, and we have used these viral vectors in a number of our other programs. So that was the basis, and we've used it for Ebola and Zika, and we have good experience from a safety perspective with it. Now, We are in phase 1. We have actually quite a large phase 1. It's a phase 1/2A that's being conducted in Belgium and the United States. And it's a trial that's evaluating the safety and the immune responses or immunogenicity of our vaccine. And we're looking at different schedules and dose levels of our vaccine in adults aged 18 to 55. And we're also evaluating the same vaccine schedules in the elderly so that we can get information as early as possible to support moving into an efficacy trial in those same populations. So we expect to have some results in the coming weeks from that trial, and in discussion with the FDA and other health authorities, if our data look good, then we will move into phase 3 immediately. So in terms of safety, we do everything that we would normally do. We look at acute reactions after vaccination. After each vaccination, it's sort of the same thing. People record their experiences and measure their temperature on a diary, and they do that for the first 7 days after vaccination. We also look for unexpected reactions during that time period, and we also look at safety and rare events in the long term. And actually for our studies, they're even longer than what we would normally do because we want to monitor for safety for longer and generate more information on the immune responses long term, because this is a compressed program. So the number of questions that you can attempt to answer early on, because you're doing a lot of things in parallel, and that's one way to accelerate, ensures that you have a robust package of data that includes safety, details on the immune response, as well as ultimately efficacy to support licensure. And so we've learned through doing this once before that really you can speed up a lot of the different things. From the manufacturing perspective, some steps can be done in parallel. They might be done at risk. If there's a failure, you have a setback, but if you don't, you really can advance much faster. So we have taken some of those risks, so to speak. One of the other main ways that we are accelerating is by making our commercial supply and upscaling our manufacturing process early. So we took that financial risk. It's quite expensive to do that. Usually you wait until you have some idea that your vaccine works. We took the initiative to evaluate that and initiate that process such that we would have large supplies of vaccines early in the first quarter of next year. In case our data support an emergency use authorization. So that readiness and preparation also compresses the development process substantially. And then in terms of efficacy, we're following the FDA guidelines. They put out a guidance document in June of this year outlining what their requirements, minimum requirements would be for efficacy trials and overall clinical development. And it's actually a bit of a higher bar than what is required for a routine vaccine that you would develop, which I think is good. So the aim is then to get definitive answers from a safety perspective, from an efficacy perspective, such that they can make clear decisions based on what they're seeing and ultimately compare the various vaccine candidates at the end of the day.
Thank you so much. We're going to stay with the vaccine. Dr. Jones, want to jump in before I go back to Dr. Corbett?
I have a question, which is,
Sure.
I have heard, so I am not an immunologist, I'm not a vaccinologist, but with previous coronaviruses and the attempts to develop vaccines, I've heard that in some cases they have made it more likely that you would get the clinical disease. Can you explain that? Is that true?
I'm happy to take that question if you don't want to explain that.
Coronavirus expert, but I can.
Yeah, go ahead and I'll fill in.
No, it's just that has been, well, you should hear from the coronavirus expert, but that has been observed with some of the MERS vaccine candidates, but not in clinical trials. But not with all. In some preclinical studies, they did observe signs of enhanced disease, and it's linked to the type of immune response that the vaccine induces. So there is a particular focus on all of the current vaccines that they basically have to have a certain type of immune response to reassure the regulators that it's not going to trigger enhancement of disease. So there are many ways that you can evaluate this before you even get into humans, and it's really looking at the ratio of certain types of immune responses or the absence of certain parameters of the immune response that can show a good reassurance that because the concern is as your immune response declines over time, that might predispose you when you're exposed to the virus to an enhanced clinical picture. So we are evaluating all of that preclinically And each company is going to have to show that they have a safe product from that perspective, and there's specific studies that you can do. But also we monitor the severity of all cases of COVID in all of our trials prospectively to evaluate that. And we actually have a separate committee that's going to evaluate all of our cases. So if it looks like that were something that would occur during the course of clinical development, that we would be alerted to that immediately.
Dr. Corbett, can you amplify?
Oh, no, she described it very spot on, with the exception of that most of the preclinical data is from SARS, not MERS.
Oh, I'm sorry, you're right. I didn't see the first SARS. Sorry about that.
But the same concept in that, to be completely honest, actually the field of vaccine-induced enhancement is something that comes from measles and respiratory syncytial virus. So even beyond coronaviruses. And with that, it is something that has been studied very intensely in the context of other viruses, even in the context of other viruses inside of the clinic. And the safety signals is actually what we've called them in our preclinical studies regarding the types of immune skewing that generally happens if there is the signal towards enhanced illness, really just have not been apparent in multiple animal models, at least for the vaccine that we are a part of. And then I've seen you guys' data, so yours is too. Yeah, I think that, you know, there was so much knowledge around this phenomenon, so to speak, that it was very easy to lay out a trajectory towards clinical development with those safety signals embedded in them. And I think that everyone's pretty happy that, as far as we can tell, enhancement should not, it doesn't seem to be an issue.
May I just ask one little follow-up on that? And I guess it would be a particular issue because for some people, the severity of the disease is because of an amplified immune response to the virus. I don't know if that was true with SARS, the first SARS. So I'm very happy with these answers. Thank you. But I just, like, it has a little bit of an extra.
Right. So what you're talking about, you've seen data around, or at least press releases around. I'm not really sure so many people really dig into the data. But what you've seen has been, you know, people saying that high-level cytokine responses and things of those natures cause for more increased disease. What we're talking about are really distinct adaptive immune responses that come from a vaccine. That's by way of the type of T cells that we trigger with the vaccine. So those T cells have different jobs and work in different ways. And so one way can push you towards enhancement, and another way can push you towards protection, so to speak. And so there have been situations, particularly in the literature around measles and RSV, where you just have this bad immune response that previously no one really knew how to characterize. But now, because we do know how to characterize it, we could pick up on that very, very easily. And there are ways to trick the immune system in one way or the other. And so, you know, Johnson & Johnson has the Adenoviruses, which does a great job at eliciting the right type of immune responses. Ours with the mRNA, same thing. And so it's a little different than the cytokine storm type of press that has come out, particularly like in the elderly, for example. Not to be confused. Yeah.
But maybe just to add one more point. I mean, the virus itself can induce that storm and overwhelm the body, and we've seen that happens with a lot of different diseases. And so that's something that we would like to prevent. And if you can reduce the viral burden, certainly that can help prevent that as well.
Absolutely.
Thank you. Appreciate that. I appreciate Dr. Jones bringing those community questions. So thank you very much. Dr. Corbett, talk a little bit about any of the latest breakthroughs, something that maybe has been surprising as you've gone through this process lately. What can you tell us?
Well, I will say that I'm surprised every single day. I can't believe I'm actually living in this moment. because, you know, starting out in coronaviruses really as a viral immunologist and really trying to just understand basic mechanisms of how the virus works, and then ending up here, you know, the most surprising thing to me was just the ability to leverage pre-existing data from other coronaviruses into a clinical product in such a short period of time. In our particular case, it was 66 days after the viral sequence was released. So that was exciting. I specifically lead the preclinical or non-clinical side. I can't call it preclinical now since we're already in the clinic, but so the non-clinical side where we test things in animal models and really dive into what's happening. And so seeing, you know, animals be protected, particularly in their upper airway, so right here in the nose, which has implications towards transmission, and just the outpouring of so much data from phase 1 clinical trials, et cetera, that really points towards a promising vaccine is very interesting to see. For me, it's also very interesting to see the number of people who are using a vaccine antigen that we described in 2017 as part of their vaccine as the literature starts to come out. And so I'm just, overall, all of the data just, for me, they look really good, and they look really promising.
Sure. Let's step, Dr. Jones, into kind of the social science piece of this, the community science. We, as a Black community, have moved through several different pandemics, if you will, and we talked earlier about our ability to overcome and to endure. What type of things, in addition to the great work that our other scientists are doing, what's going to get us beyond this? How is the Black community going to move forward and overcome this COVID-19?
We need to stay on point and keep the nation focused that racism exists. I mean, after COVID-19, it's going to be COVID-21, or it might be, you know, something, you know, so there, because of how humankind is intersecting with the rest of the world and wildlife and everything, there will be other viruses coming along. And each time some kind of challenge comes along, it's going to unmask structural inequities again and again. So our job, I am so encouraged. I'm so encouraged by the work that's been presented by the other two scientists here. But what we need to do is to rectify the structural inequity. And so, as I said, well, so let me define racism so that we understand that it's a system, not an individual character flaw. It does two things. It structures opportunity and assigns value. The basis of it is so-called race, you know, the social interpretation of how one looks. And it has three impacts. It unfairly disadvantages some, unfairly advantages others, and saps the strength of the whole society through the waste of human resources. If we can let everybody in this nation understand that when we say the word racism, we're not trying to decide, are you racist or not, or just how racist are you, but that we're talking about a system, then we need to start thinking about how are we going to dismantle this system. My biggest fear, so for nearly 3 decades, I've been working on anti-racism, right? As a family physician, epidemiologist, and now I would describe myself as an anti-racism activist. When COVID-19 hit, all of a sudden people wanted to talk to me, all the TV stations and stuff and webinars, and here we are, CBCF, right, doing something, right? My biggest fear is that 6 months from now, a year from now, that will be a thing of the past, and we will fall back into what I describe as the somnolence of racism denial. So what Black communities and brown communities and indigenous communities and white communities need to do is not let that happen. We need to stay on point that racism exists. We need to do these 3 steps of naming racism, asking how is it operating here, organizing and strategizing to act. And my anti-racist policy agenda has 4 pieces. One is reparations to descendants of Africans enslaved in the US, as well as trying to restore full honoring of treaty rights for indigenous people. So, but reparations and honoring treaty obligations. The second is decarceration. That has an impact not just on communities and people, but on COVID-19, where you have a lot of transmission there. So decarceration, and some people would even go, like Angela Davis has for decades, talking about the abolition of prisons. The third is massive investment in communities of color to address housing and green space and environmental cleanup, and then investing in businesses and in banks and education in the schools, all of that. And the fourth is, with that massive investment, extra special massive investment around families and the children. So in terms of early childhood education and all of that, because we will know when we have succeeded, when the term disadvantaged child will have no meaning. We won't even be able to imagine a child born into disadvantage or finding themselves in disadvantage. This is what we need to do. And it's not a 10-year plan. It's not a 20-year plan. It might be an intergenerational plan of passing the baton, but as long as we keep in that race, as long as we keep moving that way, and as long as we keep racism and anti-racism on the agenda, then we will be getting where we need to go.
Thank you. And it speaks to, in addition to the clinical science and the immunologic science of this, there's also, again, that social science. And to that end, something for all of you. We know that we, Black Americans, are overrepresented in 9 of the 10 lowest paid, highest contact essential services in this country. And that elevates our community's risk of contracting the virus. We know that. Can you speak to what you, your organization, the other communities in which you move, what are you all doing to advocate for these workers? Can you speak to that at all? Dr. Doogie, it looks like you opened your mic.
Oh, well, I mean, as a company, I think we're probably less directly involved with some aspects of that, but certainly where we can support, maybe I can speak in terms of the context of clinical trials, making sure that all of our staff are protected, making sure that we are inviting those people who are at higher risk to participate. There are some risks, of course, with every experimental product that you test, but there are also some potential benefits to participation. One of the questions that comes up is, how do I get tested? If my company doesn't provide testing, you can't get testing and good monitoring through trial participation, but certainly supporting policies that actually require companies to do what they're supposed to do, which is screen people, have a policy in place, provide the personal protective equipment that's needed, we certainly are in support of.
Thank you. Dr. Jones, thoughts on that?
Yes, the first thing is that what you described doesn't just so happen. So we need to recognize that it's not just a happenstance that we're overrepresented in these undervalued, underpaid, but essential frontline jobs. And so what I do actually has, I don't know if I mentioned, I've been on so many webinars even already today. So I don't think I mentioned here that out of my work as president of the American Public Health Association, there are now, last time I looked about 3 or 4 weeks ago, at least 83 counties and cities that have declared racism to be a public health crisis. It's not the health department in the city, it's the city council. It's not the county health department, but the board of county commissioners. And more, so I know if I look now, it's probably gonna be 100, and more states are doing it at the state level. That's an important thing because it's saying those jurisdictions are acknowledging that the differences in our overrepresentation in terms of the frontline jobs that are poorly paid and poorly protected. That's not just a happenstance. It comes out of schools funded by local property taxes, comes out of the residential segregation by race of our communities, and then the disinvestment, all of this stuff. So those communities are saying, public, hold us accountable. We have put a stake in the sand and we are declaring racism to be a public health crisis. Now they have to figure out what to do after that. So my job, what I have been doing is supporting that in my work as APHA president in 2016, when I launched our association on a national campaign against racism, which resulted in the first of those counties, Milwaukee County, making that declaration, which is then now snowballed. I continue to equip people with the ability to name racism, to look at structures, policies, practices, norms, and values, the different elements of decision-making. Structures being who, what, when, and where of decision-making, especially who's at the table and who's not, what's on the agenda and what's not. And of structures are the who, what, when, and where of decision-making, policies as the written how of decision-making, practices and norms as the unwritten how of decision-making, and values as the why. Equipping people with the ability to take that question in their settings and then start organizing. The third step is to organize and strategize to act. Equitable Dinners Atlanta, I would say, is something that people should look up. It is a monthly, on the third Sunday of every month from 5 to 7 Eastern, collective kind of dinner talking about racial equity and anti-racism. The next one is going to be on September 20th with Rashad Robinson from The Color of Change as the guest speaker. Each of them starts with an original play done, and then there's breakout discussions for people, for strangers to talk to one another. That kind of thing is what we need.
Excellent. And you're ushered in our last topic, and that really is kind of moving to some action. And so I'm going to ask Dr. Corbett, how can supporters of you and of the NIH contribute to your work? And I don't mean just money, but how can we contribute in helping you find a vaccine for this virus?
You know, for us right now, the most that supporters of us could do is to volunteer for the phase 3 clinical trials. So the particular vaccine that we work on is in phase 3 clinical trials, 30,000 people across the United States of America. And you know, the phase 1 data came out and we had 4% African-American participation. I deemed it the only failure that I've had in the last 7 months throughout this entire process, to be frank. And so having more African-American and people of color in our vaccine trials really will help us understand what the landscape of the protection, or not protection, but hopefully protection of the vaccine is across different demographics. And that is extremely important. And, you know, as much as we can do in monkeys and mice and hamsters, et cetera, the real question comes from the people. Well, sorry, the real answer comes from the people. And without the volunteers, it's just very difficult to do it.
Thank you so much. Dr. Doogie, many of us were unable to watch your testimony to the House Subcommittee of Oversight Investigation. Can you just remind us, what were the main priorities that you would want members of Congress to take away?
Well, first of all, I think this is a really concerted effort by the US government to support vaccine development on such a large scale. So I think the collaboration that we certainly have engaged with the US government on vaccine development, really trying to accelerate, that partnership needs to continue. And I think that's going to be critical. One of the things that I was able to share is just an update on the status of our effort and our public commitment to providing over 1 billion doses by the end of next year at a not-for-profit price for emergency pandemic use. And that will hopefully ensure that as many people as possible can have access to the vaccine. And so I think that's the main takeaway, is that we're committed to doing this and delivering a safe and effective vaccine. We hope we're successful, as we hope the other manufacturers are successful, because all of us will be required to really serve not only the needs of the US, but also around the world to really tackle and eradicate this disease.
Thank you so much. You each have 30 seconds to close us out before I formally thank you. And I feel like Dr. Doogie, you offered a good close there. Drs. Corbett or Jones, 30 seconds. What would you say to our listeners?
You know, as much as this process is deemed warp speed, really by nature of there being a necessity for a vaccine and very soon, understanding that the work that is put in on a constant and daily and nightly and weekend around the clock basis is so in depth, and none of the steps are being skipped, and that first and foremost of importance that comes out of this pipeline is a safe vaccine, and then efficacious.
Thank you so much. Dr. Jones, 30 seconds.
Well, I'm just delighted to learn so much on this panel. I actually don't know how a person would volunteer to be part of the phase 3 trial. So maybe as one of the resources, you guys could let people know how to connect, because nobody's ever reached out to me to do that, and I don't know how. I just have to say that that sometimes we get so narrowly focused on the individual that it makes systems and structures invisible or seemingly irrelevant. So as we race toward a safe and efficacious vaccine, which will help us get out of this current crisis, we have to also, all along the way, acknowledge the role of systems and structures and the fact that we can intervene on systems and structures. They are not beyond our action.
Thank you so very much. Doctors Kamikia Corbett of the National Institutes of Health, Dr. Makaya Doogie of Janssen Pharmaceuticals, Dr. Kamara Jones of Emory University and Morehouse University. We honor you for this amazing work that you're doing on behalf of the world and specifically on behalf of the Black community. And we thank you for the time that you have taken, not only today, but every day in helping us to fight this horrible disease. The Congressional Black Caucus Foundation thanks you. I thank them for this opportunity to serve as your moderator. And of course, this would not be possible without the contribution and support of Johnson & Johnson. So we thank them as well. And finally, we thank all of our participants for this virtual experience. And we hope that it has been enjoyable. We hope that it has been informative and educational. And we challenge each of you to think about what it is that you will do to help these powerhouse women, these scientists, do their work. And what will you do to protect yourself and your family while they are completing their divine task? Thank you, everybody, for being with us today. Thank you again, ladies, for your time and your expertise.
Thank you so much.
Thank you.
Thank you. Bye-bye.